results of our randomized trial in elderly glioblastoma, basically looking at short course radiotherapy plus or minus the use of concurrent and adjuvant temozolomide. This was a CCTG-led international trial in conjunction with our partners in Europe and TROG, as well as for the first time ever, 4 centers in Japan. There's my disclosures. This study was supported by the Canadian Cancer Society Research Institute. Basically, these are the funds that support CCTG, and by an unrestricted educational grant from Schering-Plough. Now is Merck, which of course is the maker of temozolomide. This was the landmark trial published in 2005, where the EORTC and the then now called NCIC CTG, basically Europe and Canada, performed this randomized trial with the addition of concurrent temozolomide daily during all 6 weeks of radiotherapy, plus the adjuvant continuation of temozolomide for 6 months in a 5-day schedule every 4 weeks. This is the very first trial, the first positive trial in over 25 years in the field, relative back to 1980 when the landmark trial was establishing the role of postoperative radiotherapy in patients with glioblastoma. This also marked the emergence of a molecular marker for efficacy, particularly the addition, which patients would benefit most from the addition of temozolomide, which is an alkylating agent. The MGMT methylation status. So the methylguanine methyltransferase is a mechanism that repairs DNA damage from alkylating agents, and methylation of the promoter gene actually turns off that mechanism. So if you have a methylated tumor, you have a tumor that will be more susceptible to the addition of an alkylating agent. And this was borne out in this trial, where out of the 575 patients, they had accurate data on MGMT methylation in 200 patients, and an analysis of that subgroup of patients, which is about 40, represents, if you extrapolate that to the whole group, it's 45% of all patients have MGMT methylation status. You look at the best group were the MGMT methylated patients who received radiotherapy and temozolomide. And here's the difference of in the methylated group between radiotherapy only versus methylated patients. And this translates to a 2-year survival of 46%, whereas you can see with radiotherapy only in the methylated group, the 2-year survival is about 10%. So it really makes a huge difference in patients with methylated tumors. The other point I want to make about this study is that of the Europe and Canada, Canada was the leading accruer of the study with 166 patients. The second highest recruiting nation was Germany at 80 patients, and this really laid the groundwork for us to be able to collaborate with them subsequently in our randomized trial. When you looked at the potential benefit of temozolomide by age in that study, first off, the Stupp trial only went up to age 70. And you look at the age 60 to 65, there was still a significant benefit in survival in the overall group with the addition of temozolomide. But in the 65 to 70 age group, there was no longer a statistically significant benefit for that subgroup. When you look at SEER data in the US in terms of the effect of age on survival in glioblastoma, you can see that in the 20 to 44 age group, the 2-year survival is about 35%. But when you get down to the age 65 to 74 group, it's 7% and 3% at 2 years in the 75 plus age group. The other issue about glioblastoma is that, like most cancers, even though it's about 4 cases per 100,000 across the population, it's skewed towards more older patients, so that by age 65, the incidence is 12 to 14 patients in the 65 plus age group annually, so that when you look at median age from the 2005 to 2009 report from SEERS, it's 64, but in fact, with the aging population occurring throughout most Western nations, we believe probably the data will show that the median survival, the median age is now 65 or 66, so it means half our patients are considered elderly and don't tend to benefit very much from our current treatment approaches. So looking at data that was available in elderly patients, so back in 2007, the French, because prior radiotherapy studies were done largely on younger patients, there was no good data on patients aged 70 and older as to whether they actually benefited from any treatment. So the French undertook a a randomized trial in age 70 plus, so that the trial had to be terminated prematurely after 85 patients because there was a significant improvement in survival from 17 to 29 weeks in terms of median survival in this age group. So it did establish that radiotherapy does make a difference even in the elderly patients where results are relatively dismal. There was also a study published from Western Canada led by Wilson Rao in Edmonton, where they randomized 100 patients age 60 plus with glioblastoma. The study was done prior to the temozolomide era, and they showed that 6 weeks or 60 gray and 30 fractions versus 40 gray and 15 fractions did not result in any significant difference in outcome, although it was a small study. So there were two other trials that had just begun at the time that we came up with our proposal for an elderly trial. And this was the Northern Scandinavian trial, dubbed the Nordic trial, where they were looking at a 3-arm study of radiotherapy only, 60 gray in 6 weeks, versus another hypofractionated regimen of 34 gray and 10 fractions over 2 weeks, versus temozolomide only, which was just emerging as a potential approach in the elderly population, being that its treatment is not very effective, and this was a much simpler treatment to administer with once-a-month clinic visits as opposed to a 3 to 6 week course of radiotherapy. So there are over about 350 patients randomized in that study, and here are the overall survival results. So on the left panel, you have the overall results, where in fact temozolomide was superior to 60 gray and statistically significant in terms of overall outcome. So 60 gray is a green curve, the reddish or brown curve is the 60 gray. There was no advantage of temozolomide over the hypofractionated group. When you break this down into the two major subgroups, age 60 to 70, there was no difference in survival between the 3 arms. But in the 70 plus group, you can see that both temozolomide and 34 gray and 10 were statistically significantly better than 60 gray. And I can only really interpret this as 60 gray being too toxic for elderly patients. And certainly that's what we'd seen in the clinic for decades before, and why we rarely ever propose 70 gray or 60 gray in patients age 70 and older. This was looking at the data by methylation data, and it was this is available in a small subgroup of patients. But the radiotherapy are the two middle arms, and it just goes to make the point that radiotherapy is not influenced by the methylation data. But if you look at the two temozolomide arms, that the outcome is significantly improved if you're methylated, in other words, susceptible to an alkylating agent, as opposed to an unmethylated patient where they actually do worse than radiotherapy only. So it just hits home the point that temozolomide makes a huge difference in patients with methylated tumors. And this will be better exemplified in this German study, which was also just beginning at the same time as our coming across with our proposal for another study. So they looked at 6 weeks of radiotherapy at 54 versus 60, depending on volume, versus temozolomide only. And they had a novel temozolomide schedule that was a little more dose intense. So 1 week on, 1 week off every 4 weeks. So 373 patients randomized, and they showed no difference in overall outcome between temozolomide only versus radiotherapy only. But again, they had a larger proportion of methylation data, and it really makes the point that radiotherapy are the two middle arms, radiotherapy only, and whether you're methylated or not doesn't influence outcome. But if you're getting temozolomide only, then the methylated patients do significantly better than the unmethylated patients. And the methylated patients do significantly better if they get temozolomide only versus radiotherapy only, which is the blue line. So our assumptions, and of course some of this data was not available. The last two large elderly trial data were not available to us at the time of our design of our study. So our original design was, our design was that radiation alone was the standard of care, would be the control arm. 40 and 15 was a widely used schedule in elderly patients and shown to be, in a small randomized study, to have equivalent results. 60 gray is maybe associated with worse outcomes, and in fact, subsequent studies have demonstrated that in the elderly. And concurrent and adjuvant temozolomide is the standard of care in age 65 and younger, as demonstrated by the STUP study. It was uncertain in the 65 to 70 group, and we had zero data on combining those two treatments in the elderly patients over 70. So the principal question was, does the addition of concurrent and adjuvant temozolomide confer a survival advantage in patients age 65 and older? Now, we had to add this little thing at the end here, deemed unfit for radical therapy, 60 gray temozolomide. And the reason we had to add this was that the Stupp study went from age 18 to 70. So we thought we'd run into a problem with the REBs if the 65 to 70 group were included in the study. Originally, our design was to just go from 70 plus. It was the Europeans that insisted that it be 65 plus, because apparently they don't give 60 gray to anybody over age 65. And so that's why we had to put that little phrase in there. And that really just applies to the 65 to 70 group. The 70 plus group, there'd be no issue. So I'll also go back to one other side. So here's the proposed study that was finally agreed to. So radiotherapy alone, 40 gray and 15 over 3 weeks, versus the same radiotherapy plus concurrent temozolomide over 3 weeks, and then followed by adjuvant temozolomide in the 5-day schedule for up to a maximum of 12 cycles or progression. And then, of course, all patients are assessed with an MR at 4 weeks after radiotherapy, and then at every 3 months thereafter. And then, of course, we measured disease progression and survival. Our original design was a 3-arm study: temozolomide only, radiotherapy only, and then the two combined. But both the CCTG and the brain subgroup of the EORTC brain committee were very wary of a 3-arm study. And in fact, the brain committee at the EORTC, the radiation oncologist would not accept a temozolomide only arm. And Merck was also nervous about a 3-arm study versus a 2-arm study. So we knew the other 2 studies looking at temozolomide only versus radiotherapy only were underway. So we agreed to drop that 3rd arm. So the overall primary endpoint was overall survival. Secondary endpoints, the usual: progression-free, adverse. Quality of life was measured with 2 well-standardized and instruments that have been validated in the brain tumor groups. And the main translational study was going to be MGMT promoter status, and obviously others that may come up over the course of the decade that took to get the study done. So the objective, we were looking for an improvement in median survival from 6 months to 8 months. And for that, with a 90% power and a 2-sided t-test, we needed 520 events. Statisticians love studies in glioblastoma because we get our endpoints early, unfortunately. So to get 520 events, we only needed 560 patients, less than a year of additional follow-up, and we mapped out an interim analysis. So we had hoped to get the study done in about 4.5 years. It actually took from 2007 to 2013, so it took 6 years. So accrual was a little slow, and mainly that was because of the huge time lag in getting studies initiated at various centers throughout the world. So at the end of the day, we randomized 562 patients, 199 from Canada, 249 from the EORTC, 97 from TROG, and 17 patients from Japan. Looking at the baseline demographics, they were well balanced between both arms in terms of gender, and 60-40 is sort of the normal preponderance of this disease in the population. There's a preponderance of males with this disease. Looking at age groups from 65-70, 71 to 75, and older than 75, again, age being a major prognostic factor in this disease, they were all very, very similar in all 3 arms. And in fact, about 30% of our patients were under age 70 or 65. And then so 2/3 of our patients were older than age 70, and the median age was 73, and that was the same in both arms. Looking at performance status, again, a quarter were grade 0, a quarter were grade 2, and 50% were grade 1. In the extent of surgical resection, about 32% only had a biopsy, which is what we see in population-based data in the elderly population, which is significantly higher than in younger patients. And then most importantly, the MGMT status, because that's a major confounder if you don't have that data. So we have the largest study with the largest number of MGMT endpoints. So we got the result in 354 patients, which represents 2/3 of the patients. And so this is the largest database with known MGMT status in the world in terms of randomized trials. And it occurred in about 45% of the patients where the status was known, which mirrors the prior studies. And the methylation patients were well distributed between both groups. So here's the overall result. So the overall study was positive for all patients, with an improvement in median survival from 7.6 months to 9.3 months with the addition of temozolomide. When you look at progression-free survival, we saw the same improvement from 3.9 months to 5.3 months with the addition of temozolomide. When you look at the methylated patients, which represents about 45% of all patients, you see a significant improvement in median survival from 7.7 to 13.5 months. When you looked at the other two randomized elderly trials, which had the same criteria for admission to study as we did, their best arm was the temozolomide-only arm in the methylated patients, and the median survival there was 9 months. Obviously, we're not going to have a head-to-head study of RT and temozolomide versus temozolomide only, but I think being that the intake criteria were similar in all three studies, I think everyone agrees that this represents the best data and the best outcome. So in the methylated patients, progression-free survival was there, and then the unmethylated, even though it's 0.055, it's considered positive in that there was an overall survival benefit from the addition of temozolomide, with median survival going from 7.9 months to 10 months. Recall that our primary endpoint was a 2-month improvement in median survival, so that was achieved. And the progression-free survival was that it was less significantly positive. But we believe the problem here is that you're looking at 4.4 versus 4.8 months. 3 to 4 months after radiotherapy and temozolomide or radiotherapy only, there's a huge issue with interpreting MRIs in that 50% of patients have worse scans at 1 month and at 3 or 4 months. And there's a huge issue in that half of those are true progression, half of them are pseudo-progression. And so that may be why the progression-free survival data is a little complicated in the unmethylated group. So looking at the toxicity, being that we had an improved result with combined treatment, as expected, we saw a little more hematologic toxicity with the use of temozolomide, but still the grade 3, grade 4 levels were very low, only about 7% for worse white blood count, and 27% for the lymphocyte worse blood count. Only about a 8% incidence of grade 3 or grade 4 toxicity for the platelets, the neutrophils, and 11% for the platelets, totally in keeping with what we see with younger patients. So the toxicity was no worse than what we see in younger patients. From the quality of life perspective, there are only 2 domains where there were differences between the treatment arms, and that was nausea and vomiting, and that was only during the 1 month to the 3-week course of radiotherapy, and this, we believe, is related to the use of temozolomide, although the difference was small, and temozolomide, very few patients have problems with that low-dose concurrent treatment, but there was a significant worse report of nausea and vomiting during radiotherapy. And then, subsequently, there was an increased incidence of constipation in the temozolomide arm, and we believe that's probably related to the use of an ondansetron as an antiemetic for the 5-day schedule. Both a little worse than the RT temozolomide arm. So, the addition of concomitant and adjuvant temozolomide to short-course radiotherapy for elderly patients with glioblastoma significantly improves survival in all patients. This combined treatment is well tolerated, it's easily administered, and it's resource efficient. And MGMT, patients with MGMT methylation benefit the most, where the median survival is nearly doubled. So James Perry and I were the co-chairs for this study. Wilson Roa was the radiotherapy QA. John Rossiter is neuropathologist at Kingston with Central Path Review. We have our colleagues who led the study in Europe and Trog and Japan. Obviously our NCIC, our CCTG senior trial leadership here. Chris O'Callaghan and Chad Winch were amazing. They were able to track down all the data and get all these tissue specimens in. And of course, this study was supported by Merck. And obviously, we thank all our patients and families for agreeing to be part of the study, and to all collaborating institutions and local PIs who are listed here. So in terms of, there's no doubt this is going to become the standard of care, if not already adopted. It's about to be adopted in most centers. After this presentation at ASCO this spring, both James and I have had innumerable emails from all over the world asking for the protocol so that they can adopt this approach for their elderly patients. As you can imagine, at ASCO, the discussant after the plenary session for this was Stuart Goodman, who was a very senior neuro-oncologist at Johns Hopkins. He sort of panned this data because he said, too bad you didn't bring in a third arm of 60 grade in 30 with concurrent temozolomide as a standard of care. And at the subsequent site meeting later that afternoon, where just where the CNS people showed up, that was challenged by most people in the room, saying that we're not going to give 6 weeks of radiotherapy to a 75-year-old patient with glioblastoma. And then the whole issue of value-based treatment. And of course, there's a huge move in the US right now to change the remuneration for radiotherapy from per fraction to course of treatment. And in fact, there's been a lot of interest by our American colleagues asking us what our fractionation schedules for palliative radiation oncology, and I think, Rebecca, you must be aware of this trend. And so that I think that most centers that we know and speak with personally, they are adopting this, but there are some holdout centers that will likely just stick with 60 and 30, although the remuneration considerations may alter that. So I'll
I would like to ask our two speakers to take the floor. In Scotland, that means you start dancing. But so when I asked them to present, I actually situated 2 questions on the basis of the international studies that they were leads for. And I said to them, what was the thing that surprised you most in taking your clinical trials internationally? And retrospectively, what would you do differently if you were to run this again? So, Charles.
So, what surprised me the most, I don't think we had any great shocks or surprises in this trial. We're very fortunate that we had OCOG coordinating the trial. It's a small group, but they're very professional and very tenacious, and they were able to identify most of or anticipate most of the problems and deal with them before they became great problems. We're also very fortunate in that we only had 2 international collaborators. Really, and both of them were former GU fellows here who I personally knew very well. Jared Martin, who is also extremely competent and enthusiastic person, personally got TROG on board in Australia. And once they were involved, they actually provided 25% of our cases, and they shortened the overall time of the trial by more than a year. In France, it became a little bit more difficult. It actually took about 8 months to get TROG on board. It took about 3 years to get France on board. And
was that related to union issues?
No, it wasn't related to union issues. It was actually related to the fact that in France it was being done through a center rather than through a coordinating group, and the lack of experience, and it became very apparent. The OCOG lawyers and the lawyers at the French Center spent 2 years arguing about the wording in a contract, which was also had to be translated into both languages. So that unfortunately we did not get as much out of the French trial as we might have, but they did eventually come on board. In terms of regrets, I think the biggest mistake we made at the beginning was not to include embed correlative studies into the protocol. We were very financially strapped. We didn't have any money for correlative trials. We thought we could stick it in later. but without having those consents from the patients up front, it actually became impossible. So I think that was the biggest mistake that we made.
So from our perspective, the prior landmark trial back in 2005, where Canada was a major contributor to the EORTC-led study, that really set the stage, because this was the first time in the brain world that an international trial was led by Canada. And so I was very pleasantly surprised when James and I approached the EORTC after getting the blessing of the NCIC CCTG that they were supportive of this study and very supportive of trying to integrate other groups. I was very pleased and surprised at how supportive and accepting the EORTC leadership was in the Brain Committee. They just took it as a given that we were equal partners, even though their population is about 10 times that of ours. Because of our major contribution to the prior study, they were very willing and eager to collaborate on a Canadian-led study. And of course, the study spoke to the question that was dear to them. We did approach the U.S., which is basically the RTOG at that time. And the problem with the U.S. is if it's not their idea, they're less likely to participate. No criticism of why, but that's just the way of the world. And I've been on the RTOG Brain Committee for 15 years, and it was really hard to get a non-US study accepted. And I'm sure other groups have had better luck, but at the Brain Committee, it's either, if it's not an American idea, it's not going to live. And so with the redistribution of the reorganization of the large groups in the US some 10 years ago, we then, maybe 8 years ago, we then, Alliance, which is another big group that does brain tumor, they were very supportive of doing this study. But basically, you only have the two groups, Alliance and RTOG. And so, unfortunately, when you go to the NCI Brain Committee, the CTEC committee, to get an approval of the study, the sponsoring organization has to leave the room. So that on the conference call, the Alliance members had to leave, and only the RTOG decided. So it was a foregone conclusion. So that was unfortunate. So not to put a point on it, but the two only randomized studies in the world that have established a new standard of care in glioblastoma did not involve the U.S. And I think that's a point that's not been lost on senior leadership at NCI in the U.S. So since the initiation of our randomized trial in 2007, the U.S. has agreed to three-part studies. So the anaplastic oligo studies, the anaplastic astrocytoma studies, the U.S. are playing ball now. So it's been interesting, very, very interesting. In terms of regrets, obviously James Perry, my co-PI, was very disappointed we didn't have a Timonol-only arm. His flight was late getting into the meeting we had with the EORTC in Paris back in 2005 or something. And I was there on my own at the podium, and it looked like the study was going to die. And I just proposed right on the spot that we just drop the Timonol arm, and then the EORTC agreed to the study. James arrives 30 minutes later, and he was ready to tear a strip off me. But we're good buddies, and better to have a study than no study. So, and as it turned out, all the data sort of supported each other, and all three randomized studies in the LD actually gave complementary data, and so it's all worked out for the best.
Thank you. So I'm going to open the questions to the floor. Jean-Pierre?
What advice would you tell a novice researcher interested in doing these sorts of collaborative research protocols?
Well, you have to be very patient, and obviously, you have to have an idea. You have to demonstrate, at least in the early work, that this idea has merit. Certainly, in our in the case of our trial, it was very interesting. It basically started as a little phase 2 trial in our department, which was mostly undertaken to prove that we could use IMRT to treat prostate cancer. But once we got those results and people started showing interest, then we could move forward. So I think the answer is you plant your seeds, you water them, you nurture them, and then you can start convincing others to move to the next level.
I'd like to add to that, and that is become part of the national cancer committees. So in our group, obviously the main coordinating group is the CCTG Brain Committee, and so become a member and then be a contributor. And there's all kinds of work to be done. So my best advice to all young investigators is become part of the CCTG committees, the subgroup committees, and the site committees, and be a contributor, be a volunteer for whatever work is required, in addition to starting with a good idea at your local institution, getting some early phase 2 data. That's the best way forward, because once you're part of a national committee, that gives you a springboard to interact with the other groups internationally to go forward.
Except that did us no good was.
Andrea?
I just wanted to echo, first of all, congratulations, fantastic work and excellent presentations. I wanted to echo Norm's comments about participating in other studies. If we participate in large international studies and contribute a lot of patients, we are more likely to be given opportunities to lead and to have collaboration on the next studies. That happened with us with RTOG, lung SBRT study as well. Question, I was very impressed with your accrual curves, Charles. I mean, it's, very rare to have an actual accrual parallel and even overlapping and exceeding the projected. And yet for patients, it was a significant difference in terms of time, same therapy, but a different time commitment, uncertainty about increased risk of late effects, etc. To what do you attribute such good accrual?
I think it was just the fortune of good timing. We actually had about 30 centers participating in our trial, and they were all interested in participating in our trial because it gave them an opportunity to implement IMRT. They were all thinking about implementing IMRT. They weren't sure how to implement IMRT, and this gave them an opportunity to do that with some central supervision. Tim Craig coached half the world in how to do IMRT for this particular trial. So the centers were interested in opening it, and to be honest, for a patient, it's a very easy sell. Do you want 8 weeks of treatment, or do you want to participate in our study and maybe get 4 weeks of treatment? We had very few refusals for that. So I think the trick was not to sell it to the patients. The trick was to get the centers to participate, and it was a lack of timing. Nothing more.
Any other questions? Anybody? Rebecca?
In both of again, I want to also say congratulations. It's a great work and many years of work putting together the practice-changing results. For both of your ideas, at the time of conception, there are competing ideas, and we encounter that situation quite commonly. Can you comment on how you position yourself, or situations where you mentioned it almost died, but you pick the position to continue the momentum? Is there any turning points like that
Well, yes, there's always there's always a great deal of politics involved with any national or international trial, and you have to somehow anticipate these things when you are developing your protocol, as the questions you want to answer and the question that you can answer. And the big challenge that we had in Canada, surprisingly, was the RTOG. They had a potentially competing trial running at the same time. It was a hypofractionation trial. When we first polled Canadian centres about our trial, they said, no, we're doing the RTOG trial. But the RTOG trial was for low-risk patients, and actually we weren't that interested in investigating low-risk patients anyway. It made it easier for us to focus on the intermediate-risk patients. So in fact, we ended up having a trial in Canada, the RTOG centres, which just about everyone could compete with. But it was an interesting revelation to me that the RTOG does have the ability to sort of support Canadian innovation even within our country.
Yeah, I think I already spoke to that issue, and that first off, it was getting to the RTOG issue. It's a big issue in Canada because many of the centres are RTOG centres, but they didn't have an eligible trial, so that there was no competition. So we had good approval right across Canada, but we just wanted to tap into the large number of centres in the RTOG because we put us over the top much sooner. But other than that, we just encountered that issue in Europe and some uncertainty with the sponsors about a 3-arm trial versus a 2-arm trial. But as it was, there were 2 other randomized studies already answering, looking at radiotherapy versus Timolol only, so that made it easy to drop the Timolol only arm. Although it would have been nice to have had all 3 arms here, but you have to make compromises, otherwise you just can't get the study done.
So in the interest of time, I would like to sincerely thank both our presenters this morning for an excellent session, for sharing their wealth of knowledge and their wonderful research results. Thank you.